Hello, and a very warm welcome to this webinar to mark the launch of the Usher Innovation Community. I'd like to say that this is an extremely well-attended webinar. I think we have 190 people registered to attend. So once again, welcome to you. My name is Pennie Taylor. I am a journalist, a health and social care specialist, and I'm increasingly aware of the importance of data to drive improvement and innovation. So we're here to celebrate the launch of a new data community, supporting real collaboration between academics, service professionals, and industry. The idea is that by coming together, we'll develop new solutions to transform the delivery of care and improve outcomes for people. We're going to hear a lot more about this over the next 1.5 hours. And so if I can just turn to a little bit of housekeeping, I can talk about how you can get involved, because it's really important that you take part in this webinar if you want to. So the webinar is going to be recorded and will be made widely available on the website and on social media, and a link will be sent to everyone who's registered. We want you to join in, so please use, there's a couple of symbols on your screen, Q&A, questions that you might want to put to individual members of panels or people you're hearing speak. And if you have an object for your question, please identify them and I'll put it to them for you. The chat function at the bottom of your screen is for any links, any additional comments, any asides and discussions you might want to have as we go through the programme. But if you could put your questions in Q&A, that would be great. We have automated closed captions, and they can be accessed via another button on your screen. So please click on that to get those captions if you'd like them. Now we're going to move into an agenda. We've got a relatively short space of time to cover some extremely rich topics. So the community that is we're celebrating today is led by the Health and Social Care data-driven programme, which is hosted by the Usher Institute at the University of Edinburgh. Please join me in welcoming the HSC DDI Programme Director, Dr. Marcus Harrison.
Hi there, Pennie, and welcome to everybody else on online. Okay. So I joined this program a few weeks ago. I was really excited by the huge potential impact that data has to transform health and social care. As we all know, health and social care services are struggling globally to transition to the challenge of an aging population, particularly in a sort of post-pandemic world too. People are typically living longer, multiple long-term disorders over several decades, and we all know hospitals are full. Placing the data at the centre of response to these challenges is crucial, improving services and a combination of research, innovation, and planning for the future. With secondary and primary care data now routinely collected and linked with social care data following close behind, the time is perfect really for provide a holistic picture of how we can improve these services. As Pennie's already mentioned, today we're officially launching the innovation community to academics, industry, and care providers. And we're really looking to find solutions within those groups and within those communities to solve these pressing needs. Next slide, please. So the aim of the community is to establish a collection of partners from both private, public, and not-for-profit sectors to actively work together, find data-enabled solutions, mine the data, bring benefit to health and well-being of citizens, first in the southeast of the Scotland region, the rest of the UK, and actually beyond. Initially, this community will be virtual, and I'll provide more details about that later. And we'll have a dedicated physical presence from January 24 onwards. The community, what we're aiming to do is actually to provide access to expertise and understanding of the complex challenges, some of which we're going to hear about today. And also those are the opportunity to form novel collaborations between academia, industry, not-for-profit and care providers to find new ways of actually addressing these difficult and complex challenges. And the way we're going to approach this is accelerate this through specific demand signal challenges. Again, there'll be more about this during the course of the webinar. Underpinning all of this is actually a unique service what's called based around DataLoch, which provides rapid and secure access to really highly identified, curated and integrated health and social care data sets. This service has been used within Edinburgh for the past few couple of years or so, and this is really the first time that we're actually opening it out to more broadly outside to the community. Mentioned there'll be a network of experts to sort of support projects. It won't be just about getting access to the data. It will involve those experts to work with that data and work with the researchers at the University of Edinburgh. And it's also worth flagging that Edinburgh has an international reputation for health data research. Next slide, please. So DataLoch is actually a collaboration between the University of Edinburgh and NHS Lothian. And what it does is provide access to highly curated data sets. And I say this has been utilised for the past few years from both of the organisations, and it's actually instrumental in providing evidence around the COVID pandemic, particularly on vaccinations. And it sort of led the world here in providing information to help policy and help us get over the first stage of the pandemic. So the four key things that come to DataLoch is it's integrated health and social care. The social care data is now being added. It's the first repository that has both primary and secondary care data embedded together and connected. It has longitudinal data sets across lifetimes. So this gives you a good full picture of individuals and their comprehensive studies. And it is provided through a secure and professional service enabling speedy access to data sets. And all these data sets have been curated by experts that provide the high quality and rapid access for the projects of interest. I think it's also worth actually stressing that there's a high level of governance here and the ethics across all the data sets in line with NHS regulations and good practice. Next slide, please. So how are we looking to sort of work here? Well, we've as I mentioned before, we've been running this project for a few years now, and the areas where we're sort of having impact actually is around sort of the service management, supporting improved services both within secondary, primary, and hopefully sort of further down the line in social care too. It provides great data sets for research, providing new insights from solid data-driven evidence, which can be mined. There's also projects which are looking at industrial innovation, how to bring new products and services into the NHS. Sometimes this happens much too late. And what we're trying to encourage here through the community is actually to allow people to engage very early on to make sure that downstream that these products are fit for purpose and can be easily adopted. And then finally, also the DataLoch has been used for changings to health and social care policy. I've mentioned particularly during the pandemic, but we believe this is a strong area where we can mine this data and come up with new supporting evidence for policy changes. Next slide, please. So this whole project is part of the initiative of a wider city deal between the University of Edinburgh, UK and Scottish governments, the Edinburgh Council. Grace will be talking about this more in depth shortly. And the part we're actually talking about here is the data-driven innovation partly to make Edinburgh the data capital of Europe, but also for the health and social care improvements. There are investments across a number of other areas across the university: artificial intelligence, informatics, financial, cultural, food production, robotics, and public sector. But that, if you wouldn't have an interest in any of those, take a look at the DDI website. So really sort of iterate here that the community is actually going to be virtual to start with, and we are based on the Edinburgh Bioquarter, which is co-located with the infirmary hospital here, along with Health Innovation and the recently built Cell and Gene Catapult incubator. And really what the Bioquarter is looking to do is to become a real hub of healthcare and life sciences for the future. Okay, and that's all. So I'll be happy to take any questions now, Pennie.
Thank you so much. I'm really hope that we get questions starting to come in from attendees to this webinar. So actually, this is now an opportunity for us to find out more about the people who are joining us today. And I think we have a poll. And there is a question on it. And the question is, what would you find the most valuable from this community for you? You get a single choice, and if you would click on either connecting with experts, timely and secure access to data, collaborations across the sector, or other, that would be brilliant. We'll get some responses in. And while we're waiting for people to input their choices, just to remind you, we've had 191 people registered to join this webinar. I'm really hoping that they're happy to take part in our poll as well. And also to remind you, if you've got any questions that you would like to ask, please put them in Q&A. And so we have one question. Thank you very much, anonymous attendee. I'll come to that in one moment, but let's have a look at the results of that poll before we go there. And anonymous attendee, there's also going to be lots of opportunity to put questions later, so don't worry about that. So around 9% of you say that connecting with experts would be for them the most important, the most valuable part of being part of this community. Timely and secure access to data, 27%, 61% collaborations across the sector, and 2% other. I'd love it if we could ask the 2% of others. If you wanted to expand on that, you can do it with a name beside it, or you can do it anonymously in Q&A. Please go for that. Marcus Harrison, before we leave that, can I ask you, are you surprised by any of those findings?
Not overly. I think what's really encouraging is that the people want to collaborate, which is actually what the community is there to do. So I think that's a really great start. Thank you.
Yeah, and now we've got a lot of questions coming in. Let me ask just one of them at this point. We're going to pick this up later because we have a panel as well. But Marcus, you said social care is now being added in terms of DataLoch. Can you, explain what specific data this might include? Don't get too specific, but just broad brush.
I think where it's going to, the data will start to come in first of all is through care homes. It'll be around sort of care. It'll be focused around sort of helping care packages for people at home and in care homes. That's really where we're sort of looking to focus to start with.
Thank you so much. And as I say, we will have the opportunity to talk about all of this in greater depth in a very short while, but I'm going to move us on again, exploring why this matters. I'd like to introduce, if I may, Dr. Grace Vickers. And Grace Vickers is the Chief Executive of Midlothian Council, committed to reducing inequalities and a data-driven innovator in her very own right. Welcome, Dr. Grace Vickers.
Thank you very much, Pennie, and delighted to be here with you today. So as Pennie says, I'm the Chief Executive of Midlothian Council and also have the pleasure this year of chairing the Edinburgh and South East of Scotland City Deal, which was referenced there by Marcus. So I'm going to split today's presentation into three main parts. Firstly, a bit of an introduction about the City Deal, then talk more specifically about our integrated approach to place in Midlothian, and then finally taking a closer look at how we are transforming health and social care in Midlothian by using data. And today I will share specifically how we're actually helping older people stay in their own homes for longer using our e-frailty approaches. So the next slide, please. So the City Deal itself is a really exciting 1.4 billion place-based approach to regional partnership working. So we have 5 main work streams and we're working across the 6 local authorities across the South East, funded by UK and Scottish governments, with the FE sector, HE sector, also the third sector and the wider business community. So if you could share the next slide, and I'll talk just a wee bit about the 5 work streams. So we're split across 5 main work streams: innovation, skills, transport, culture and housing. But for the purpose of today's presentation, I'm just going to talk specifically about DTI, and Marcus already referenced that. So our ambition is to be the data capital of Europe, and we have innovation funding of 350 million. And in the bottom corner there, you can see a picture of one of the robots from the Robotarium, but we're also developing, as part of today's launch with the Usher Institute, how we're actually using data to really improve services for people in the local communities across the southeast of Scotland. So if we can share the next slide, I'll just talk specifically about why place matters in particular. So across the southeast of Scotland, we're actually the fastest growing region in the whole of Scotland. And Midlothian, my own local authority, is actually the fastest growing local authority in Scotland. Scotland as a whole is growing at 3.2%. Midlothian is growing at 13.8%. So to cope with this, we've adopted a place-based methodology. So if you could click another couple of times, 2 graphics should come up. Now, we are the fastest growing local authority, but our demographics for the fastest growing age groups are 0 to 15 and over 65s. So we knew that we needed to do something very, very differently. So we looked at the 17 UN Sustainable Development Goals and thought there's a lot in that. So no poverty, zero hunger, and good health and well-being, good quality education and so on. So we needed to think about how we could have an integrated systems approach to delivering this, which placed fundamentally early intervention and prevention at the heart of our work. So we've got one great goal that we're working towards, and we want to create a well-being economy where our people and the environment flourish. So essentially reducing inequalities at the same time as looking after the health of our planet. So we wanted to take this life journey approach, which I hope this roadmap shows. So we're actually organising, rooted in data, planned services from birth to death for the population of Midlothian. And I wanted to focus in on goal 3 for us, which is transforming health and social care. And I wanted specifically to talk about how we are using data to improve the care of people with frailty in particular. And I think there's maybe another 3 clicks just on this. And I thought the simplest way to describe what we're doing was just around using a few infographics. So firstly, we wanted to identify people before a crisis took place. And we wanted to begin to bend our spend so that we could plan ahead, particularly workforce planning. And we also wanted to access preventative support at the right time. And for us, really, the e-frailty index really held the key. We also worked out in terms of the cost of services and started to think, well, firstly, we're not going to be able to afford this if we keep this older model that we were working with. And secondly, there's no way we would actually find a workforce that could deliver the care needed. So we wanted to shift from being reactive reactive to proactive and developing robust processes, but also building relationships. So it was nice on that poll, you could see the making connections there. And we actually work on this pilot with the Usher Institute, the Home First team, and also the British Red Cross. We're also finding that more people are supported in their homes rather than hospital, less demand on acute services. And as a next step, we are now using ACP as part of our model too. I've got one more slide, but I've also put in the slide just a link. So I've got fantastic staff in Midlothian, and my thanks to Jamie McGaw and Amanda, because they talk beautifully in some of the links there. So if you want to hear more about the project, the Living Well in Communities videos will tell you a lot more. So just on to my last slide, I just wanted to show what our old model was like, what we've done, and what our new model is actually like. Now, we've really shifted that balance because we have 12 GP practices, so we work as one cluster across Midlothian, and our GPs were saying, well, actually for them, frailty is actually their climate crisis, if you like, and we really needed to shift that care. And when we first started to look at frailty, we thought we probably had about 3,500 people in the community living with frailty, but actually by adopting the e-frailty model, we actually found out that we had 8,500. And we worked really closely because we were previously relying on a lot of hospital data, when actually we realised that our GP practices held a lot of this data. And we started to use opportunities like COVID and flu vaccinations to actually gain a lot of data from people, asking them to undertake questionnaires, but also more importantly, connecting in with phone calls and home visits so that we could proactively work out a model of support that was actually going to help people live in their homes for longer. And it might sound a bit mad, but we also use that data to plan routes where we grit in the winter, because some people were saying actually they stay in and don't go out and meet people because they're really worried about falling. That made us actually worry about loneliness. So we wanted to do something to make sure that older people could actually still get out and about in winter. We've been really lucky because we've had a range of funding that we've actually tapped into that allowed us to actually have a data analyst that worked at the centre who could quality assure all the data, but most importantly for us, set up a collaboration so people could actually share the practice in order to begin to shift from the old model to the new model. So I'm really pleased to say that our new model is now in place, where we're identifying frailty at the practice level. We've got improved access to contact primary care frailty team. We've also got high continuity and coordination between care and the PC frailty team. We also are actually anticipating care interventions. That's allowing us to bend the spend towards that, and also improved access and lower threshold for contact, which is absolutely fantastic. So as I say, you can find out more in the hyperlinks. We're more than happy for people to make contact with us in Midlothian. It's something that is really, really working for us. We're absolutely committed to early intervention and prevention and continuous improvement, and we'd be really pleased to link in with other people that want to try the same. So thank you, Pennie. I'm happy to take any questions.
Wow, the whistle stop presentation. Thank you very much for that. Extremely rich in information. And just to remind everybody joining this call, if you'd like to put a question on what you're hearing, please put it in the Q&A section of the screen, and we have a chance to come back to a panel session. But I wanted to pick up one of these questions that I think picks up from what you've said, Grace Vickers, which is, James Marple has asked, will there be a focus on actionable data at the level of individuals to improve service delivery? And I wondered whether that informs the work you're doing in Midlothian. Is this kind of real-time stuff?
Absolutely. And for us, Pennie, beginning to move into predictive analytics is something that's really important for us, particularly if we're thinking we all have workforce challenges. So how do we actually help the schools, the FE sector and so on build that workforce for the future? So we're actually building, and I've opened our first centre of excellence. It's a secondary hub for digital, so that we're actually skilling up our children and young people in those future skills that they're going to need to help actually form a workforce of the future. So actually looking at the data, not just to help older people for frailty, is actually informing what we need to do to build the workforce of the future. And I cannot praise the work that we're doing with the Usher Institute highly enough, because you need those specialists. That level of analysis we can't do at local authority level. So we really need to work in with those data scientists to help us achieve that.
But using, you know, the actionable, the data that you've got, can you use that to make quick changes that benefit people?
Absolutely, and all of that built into care plans. Now, it's in a way easy for me to say that. We're a relatively small local authority, so we've got 93,000 in our population, but absolutely we need to get into that, being absolutely proactive and having those conversations individually. And we've got one mantra in Midlothian. We say one size fits one, not one size fits all, but one size fits one. And that's one of our 9 drivers for change. And that's really helping people understand it's the people on the ground that we actually need to help.
Okay, fantastic. There's so many other questions I could ask you, and I'm sure others will have their own, in which case, please put them into the Q&A. We're going to come back to a panel later on, so don't worry, we have lots of opportunity for addressing anything that might be outstanding for you. And I think you can also upvote any questions that are asked that you would like to ask, and that kind of promotes it up a list. Thank you, Dr. Grace Vickers. I'm going to move on now and invite Dr. Atul Anand, who's clinical lead with DataLoch, to give us his presentation. Welcome, Dr. Anand.
Great, thank you very much, Penny. Yes, I'm very much going to build on the talk you've just heard, actually. So talk a little bit more about DataLoch, give a bit more detail onto what Marcus introduced at the beginning, and then also, similarly to Grace, talk about some examples where I've been looking at frailty and multi-morbidity. So if we can move on to my first slide. Thank you. So, just by way of repetition but introduction, DataLoch has a purpose to harness routinely collected data from primary, secondary and social care. And as mentioned, for Edinburgh, this is at least the first time that we've brought together GP records with hospital records and using that to try and address system challenges through research, innovation and better service planning. And you've already heard that DataLoch is funded through the Data-Driven Innovation Programme, but it is very much a collaboration between the university, the NHS and 6 local authorities around Edinburgh and South East Scotland. And right at the very heart of the data service is accountability to the public. And we have a very strong public reference group. Marcus mentioned about our ethics review processes and all the steps we put in place to make sure that although there is all this data available, it's being used for appropriate reasons. Let's go to the next slide, please. Now, I don't really have time to go in great detail into every single data set, but I thought it would be helpful just to describe in broad brushstrokes what we have within DataLoch at the moment. We have about 1 million people currently resident within the Lothian region who are within our system. And that includes data from over 100 GP practices, 20 data sources, lots and lots of visits to general practice and also to hospitals. So we have ways of defining health conditions. We use standard codes that are used across the UK and across the world to bring together primary and secondary care records to define important health conditions. We have prescribing information from the community and also very shortly to include all of our hospital sites within Lothian and wider that have moved on to electronic prescribing. We know when people are attending GP practices, when people are attending hospital, outpatient clinics. And as mentioned, we are working very hard with the health and social care partnerships to bring in information around care provision and people in care homes. We also have lots of investigation data, so blood test results and similar things such as COVID-19 results. We stood up a COVID-19 registry early in the pandemic, and that's been used for several projects. And finally, very important for lots of service improvement work, for innovation and for research, is being able to define clear outcomes in a population. So things such as being admitted to hospital, being admitted to intensive care units, undergoing procedures, or death can all be established from the data that we have within the DataLoch. So if we move on to my next slide, please. So I wanted to give a couple of examples of projects where we're trying to make this actionable. So you've already heard from Grace about the the brilliant frailty work that's been going on in Midlothian. Within DataLoch, we've been also working with another part of the region, with the cluster of GP practices in North East, Edinburgh and Leith. And they've been very keen to try and improve their identification of frailty. And so we used the records that we get from the GP practices in that cluster to design a report, an automated report, which you see on the left, or extracts of that report, showing the levels of frailty amongst the GP population and providing some basic measures that could allow the GPs to track what was going on with that population. We've then worked to make that into a live clinical dashboard for all GPs, working with NHS Lothian Analytical Services, and that's what you see on the right. And this is just being rolled out across Lothian, so that individual practices can log in and see in real time the proportion of frail patients that they have within their practice, and also importantly, including in their process measures of good care. So we know that for frail older people, it's important that medications are regularly reviewed, and we can track how successful individual practices are at completing these polypharmacy reviews. That's a really good example of how we can use data to hopefully drive improvements in care, and we are seeing some early signs of that from the work with the North East Edinburgh and Leith cluster. Move on to my next slide. We also have an interest in multimorbidity. So multimorbidity describes people who have more than one chronic long-term health condition. And there is a newer terminology that we are increasingly thinking about called complex multimorbidity, which refers to an increasing population of people who have more than 4 chronic long-term health conditions. So this report, which is going to be rolling out to GPs across the region shortly, will provide individual practices and clusters with a view of the most common long-term conditions that we are seeing within GP and hospital records for patients within their practice, to show how this is changing over time, so that practices can understand their most commonly new diagnosed long-term conditions. And we hope this will not only stimulate a lot of interest in terms of understanding the population of patients better, but also thinking about how we design and shape services going forward, so that we're prioritizing appropriately for the population that is now being looked after. And so practices can compare how their incidence of new conditions is comparing to other practices within the region and the region overall. And importantly, we're including in measures such as socioeconomic deprivation, which we get from the Scottish Index of Multiple Deprivation Score, which is a Public Health Scotland provided measure. And so we really want to make sure that we're helping to target the best possible care to the most vulnerable people who potentially have signs of deprivation, but also an increasing number of long-term conditions. We can move on to my final slide. So that's really very much a whistle-stop tour, but I just wanted to emphasize and finish by this idea that we have a whole load of really, really complicated health and social care data, and it sits in many, many different data sets, different formats, and it's traditionally been quite siloed and quite separated. And the purpose very much of DataLoch is around trying to bring some order to that complexity and try and make it more research and innovation ready, and make it actionable for people to do brilliant things with it. And we really think this can be a successful platform for innovation. My colleague Susan Shenkin will be talking a bit more about that in terms of frailty in a few minutes' time, but I'll stop there. Thank you very much, Pennie.
Thank you so much. Really fascinating. And I think, you know, we're seeing, I think, in the Q&A and the chat, real collaborative thinking here. A few people are alluding to, you know, this is happening in Lothian. Yeah. Can we get this DataLoch idea rolled out across Scotland? Could this be a once for Scotland innovation?
Well, I saw in the chat as well that we have representation from other safe havens. So DataLoch is a safe haven or trusted research environment for South East Scotland, but it's important to acknowledge that there are 3 other safe havens in Scotland that work across the country, and they do brilliant work as well.
Are they working together? Are you working together?
Yeah, so we are increasingly working together, and I know that people from DataLoch attend meetings where the safe havens are coordinating what they're doing through Research Data Scotland. And so there is very much a a national approach for Scotland that is being developed as well. Inevitably, the sorts of data and the sorts of opportunities will vary by region. I think it's appropriate that we have both a regional and a national approach to these things.
And Caroline Westmoreland asking, how does she and her team access DataLoch on a locality basis to help inform?
Yes, so there's lots of information on the website. Definitely just drop us an email. We're very happy to talk to anyone in the region. We want to increasingly, we've gone through GP clusters, but we are also working very much with the health and social care partnerships. You've heard obviously already from Grace. So it's important that we make these connections.
And we're going to pick that up again in a moment. But if I can just ask you one last question, it's a complicated question, but if you could answer it very briefly, that would be great. How are you approaching recording issues? Everybody has their own way of doing it, particularly, I think, in primary care, perhaps.
Yeah, so this really speaks to data quality and understanding whether we can compare things on a fair basis. And that's a really big part of what we do. So it's very easy to think that everything stops when you just bring in a new data source, but there's a whole team behind DataLoch that work on looking for inconsistencies, producing quality reports, and all of that is important to inform how we then give that data out to people.
Fantastic. A lot of great work going on and a lot of questions being raised that we may not be able to get to here, but I'm assuming that we'll be able to answer these questions even post-webinar. So if there's anything outstanding, it'll be picked up. I'd like to move on now to a presentation about enabling technology from Garrett Sprague, the Chief Executive Officer and co-founder of Smplicare. Hi, Garrett.
Hi there, everybody. Can you hear me okay?
Yes.
Great. Awesome. So thank you so much for inviting me today. My name is Garrett Sprague, as Pennie said, and CEO and co-founder of Smplicare. So we are an Edinburgh-based data-driven software startup that's committed to driving forward predictive, preventative solutions, proactive solutions, kind of fulfilling some of the vision that you're hearing throughout the other presentations today. We're really specifically focused on helping older adults live safe, healthy, happy lives at home for longer. And our first focus is around preventing falls. So we've got some groundbreaking R&D underway that I'll spend kind of most of the time talking about today. But if we want to move to the next slide. So in terms of the team, just very quickly, myself, I'm joined by Alexander Reisig and Dr. Adrian Smales. Dr. Anand, who you've just heard from, has supported us as kind of our independent medical advisor throughout the kind of early stages of the company. And then we're also joined by Dio Samuel, who's our first hire on the team, and he is a UX UI designer. So I'll dig into a little bit of kind of why we went with a designer instead of a technologist for the first person that we brought in externally. We've got another team of 4 committed analysts and a great suite of advisors, which maybe hopefully some of the folks on the call today will be interested in connecting about in the future. So we can go to the next slide. This slide is probably embarrassingly oversimplified given the audience today, but I wanted to just kind of share a bit about where it is that we're focused, and I think you'll hear more about kind of frailty or much more familiar. So if we take my grandma Emily, for example, we look at over the course of her life, she's kind of accumulating a deficit, if you will, becoming less resilient over time. What we're focused on is kind of the transition, the little circle on the bottom right-hand part of the screen, the 2 different trajectories there. So in my grandmother's case, what happened with her is she experienced a fall, which was a very rapid sort of decline initially, and like 60% of the population who have experienced a fall, she fell again within the next 12 months. It was much more devastating. She wasn't really able to bounce back to the extent that we had hoped. We worked really hard with lots of different sort of great providers, home care providers, sort of inpatient rehabilitation, occupational therapy, et cetera. But it kind of accelerated the decline for her. And what we're focused on is, can we prevent those falls or reduce the number of falls so that it's sort of to prolong the sort of the maintained stage, prolong independence for older adults. I can dig into this more with questions. We can go to the next slide. So what is it that we're actually doing at Smplicare? We kind of look at it over 3 different dimensions. One is we help people kind of understand what to measure. We can basically pull data in from a range of everyday wearable devices, digital health devices like body composition scales initially, and we're expanding that with other manufacturers and providers to include things like thermometers and blood pressure monitors, oximeters, et cetera. So pooling data into one place, and then we use artificial intelligence to identify patterns between the sort of disparate data sets, if you will, but also develop machine learning algorithms to proactively alert risk around things like falls. So we won't be able to say this individual is going to have a fall in the next 5 minutes or the next 5 hours or the next 5 days. What we will be able to say is this person is at an elevated risk of a fall. Today is not the day for them to stand on the chair and change the light bulb, for example. And then we hope to kind of work with councils or with other partners to kind of personalize signposting to service providers that can help accelerate the path to intervention. And that's kind of where we sit. We can move to the next slide. So the research that is currently underway, we've been funded by UKRI with quite a large grant to conduct what we feel is maybe kind of unprecedented scale research. So we are funded to provide 300 diverse older adults across the UK with a free wearable device from either Fitbit, Garmin, or Polar, and a body composition scale from either Tanita or Garmin, completely free of charge. And what we'll do is we'll ask them to wear the device and incorporate the scale on a weekly basis into their kind of process. And we'll collect data over a 6-month observational period that will create from the bottom up a robust data set, effectively in almost in real time, that will allow us to build the machine learning algorithms that we've talked about today. So you can see the list of partners that we have that we're working with right now. Lots of housing associations, councils, assisted living facility providers, integrated retirement communities, kind of every real flavor of sort of older adult living support or housing has signed up to help us recruit research participants. What I'll say to the group today, we've got 250 kits kind of unclaimed. So if anybody wants to collaborate with us on identifying potential folks that might benefit from the research or be interested in participating, would love to hear from you. We are actively working with our partners to recruit research participants into the study and hope to have that wrapped up by the end of February. Why falls is kind of self-explanatory in the context today, but I think somebody mentioned earlier, maybe Grace, the fear of falling. When we've been engaging individuals, the fear of falling has almost been more debilitating than the fall itself in some ways, just as somebody mentioned earlier, the kind of cascade of impact around mental health and loneliness and the other things that go along with kind of not engaging with your chosen lifestyle and with the community the way that you hope to. Can go to the next slide, and I can kind of wrap up here. So the things that we're excited about with Usher are kind of helping us find organizations who might want to pilot our technologies and accelerate our path to market. The data and is fantastic. I think the thing that we just kind of caution around is Adrian produced his first algorithm, which won a number of awards and was related to the preventing falls. It was trained on 80% white Scottish women, right? It's a fantastic cohort of people. we can't develop AI just on people that look like me, which is the current kind of situation that we have. We need to find representative data sets for us to develop these technologies off of. Otherwise, they won't be applicable in kind of a global scale, kind of other markets outside. And so I think that's an emphasis that we really place in the work that we do. Collaboration, as somebody mentioned earlier, and the last piece is around co-design. One of the things that we've discovered in the early stages of our research has been a lot of folks ask older adults around their level of confidence with technology. It's not a fair question to be asking, in our opinion. I think the question that we need to focus on, or the sentiment that we need to focus on, is more curiosity around the use of technology and acknowledging that these folks have not really been engaged around how technology can fulfill their aspirations. And I think that's what we're really focused on. And one of the reasons why we were selected for the UKRI competition was our emphasis on co-creation and co-design, and really engaging people with lived experience around the development of our technology. So yeah, hopefully that gives enough, but yeah, thank you. Thank you so much.
Thank you so much, Garrett Sprague. Just a quick question from me before, obviously, we're going to get into the panel. Oh, actually, here's a question from Simon Bradstreet for Garrett. How can we better respond to that fear? We know from wider evidence in psychology that can be more disabling than the condition. Can your approach offer direct intervention for fear? If you could answer that very briefly, that would be great. Thank you.
Yeah, sure. I mean, I don't think right now, Simon, I have the answer to that question, but I think what we're doing is positioning ourselves to explore the answer to that question. So yeah, I think that's.
But join in, you can connect and you can get the answer later, Simon Bradstreet, possibly. Yeah. And Konstantin Georgiev says, great talk. Are you planning to adapt any explainable AI or similar inference tools to decompose what frailty risk means on a case-by-case basis? Again, and I'm sorry to do this to you because complex questions.
Yeah.
Super.
Yeah, I mean, super technical question. So
yeah.
I think short answer, yes. Sort of identifying linkages and patterns amongst the kind of robust data set that we're cultivating here is absolutely something that we're focused on, and kind of the tools with which we use are still kind of, we're exploring, and happy to kind of take that offline. I think that was probably a jargon heavy response.
That's fine.
So
Thank you
yeah,
so much. And I think it shows the value actually of this collaboration, doesn't it, that these questions are coming right now. Thank you so much, Garrett Sprague. We're going to come back to you in a few minutes. But before then, let's hear from Dr. Susan Shenkin, reader in Aging and Health at the University of Edinburgh and honorary consultant in medicine of the elderly at NHS Lothian. Welcome, Dr. Shenkin.
Thanks very much, Penny, and great to see everybody today. Like Dr. Anand, I'm a clinician working with older people, and I think you've seen over the course of the presentations today the value of this community of bringing together clinicians, academics and clinical academics, other academics too, and innovators and the digital industry in answering some important questions. So I hope you're starting to see the important part that Usher Innovation can play in all of your journeys, and we're really delighted to have all of you here with us today. My role comprises lots of different things, and in my academic role, I'm also part of the Advanced Care Research Centre, which may also be a useful resource for many people on this call, so we can put a link to that in the chat also. And my clinical role is the thing that I'm particularly engaged with this Usher Innovation as a service advisor and NHS strategic lead for this data-driven programme. Next slide, thanks. So this is just to follow on from Dr. Anand's presentation, where he showed you how we have all this complex health and social care data, and DataLoch helps us in Lothian to put that in a more systematic way. And then together in this Usher Innovation Programme, we're looking to develop a platform for that innovation that we can work across sectors to build on. So today, I'm just going to speak very briefly about our vision for a future challenge that we're going to present. Next slide, thanks. So part of our Usher Innovation Community is not just building the community and making these connections and having these great ideas, but it's also to develop some specific challenges where we can go through a process to hopefully go from idea into adoption into the NHS ideally. and that's through our partnership. That's through our partnership with Health Innovation South East Scotland, HISIS, and other collaborators in the NHS. We're hoping ultimately to build a pathway into market. But in order to do that, when, as you well know, if you have an innovation, you have to go through a series of pathways. And here in Usher Innovation, this is the vision that we have for taking any idea through towards an adoption pathway. First of all, we need to identify firstly the population of people of interest. So, for example, DataLoch can, as you heard in Midlothian, this sort of data can be used to identify people living with frailty, and that could identify a cohort of people. But we don't only want to identify the population, we have to work out ethical ways to invite them to take part in research and to engage them in potential opportunities like the sort of thing you were hearing about from Garrett. But as well as identifying the individuals, we need to identify the potential technologies out there that we would want to evaluate and assess. We'll develop a process for doing that, and then go through the next stages, looking at evaluating these individual innovations that we identify, and using the strength of the expertise in the university community, work with companies to validate these and test them in the appropriate challenge environment, with the ultimate aim of taking them through to adoption in clinical services. Next slide, thanks. So the first challenge that we are planning to launch in the spring of next year is for this really important issue that you've heard a lot about already today. It's no accident that this is informed by the expertise of the community that builds up Usher Innovation, and both Atul and I as geriatricians are very aware of the impact of frailty on services. But any of you who have older relatives or who work in health or social care, or who read the news or have been part of the community, are aware that the impact of this increasing impact of multiple conditions that contributes towards frailty. And this lovely infographic, or very emotive infographic, which was developed by one of the PhD students in the Advanced Care Research Centre, shows an appreciation of what frailty is. It's this accumulation of the burden of healthcare, which then means that somebody is less able to bounce back from an individual stressor from the initial fall and develop this gap between normal and accelerated aging, which then has the impact that they have less years of the healthy active life we would all prefer to have, and more years lived with that burden of increased disability. So this is a massive innovation opportunity to allow people to live better with frailty, to predict and prevent frailty, and to identify the conditions associated with it and act on those as quickly as possible. Next slide, thanks. So the challenge that we're planning to launch in spring of next year is, can we predict or prevent decline in people with frailty? And it's an ideal opportunity, as Dr. Harrison explained earlier, to bring together industry, academia, and health and social care providers with the power of DataLoch to start to answer these questions and to develop new technologies to work with people to develop the answers to these in the future. And we hope very much that we can work with you to do that. We look forward to discussing this further in the questions. Thanks very much.
Fantastic. Thank you so much. Before we move on to our panel, Dr. Shenkin, I wondered if I could raise a question that's been posed by Keith Allen. I'm not sure if he intended it to be directed to you, but Keith asks, if we wanted to look at something other than frailty as the outcome, say putting a focus on the impact of deprivation in rural settings, or to pick up Garrett Sprague's point about diversity, other groups' impacts, could it be applied in different ways like that?
Well, I suspect that's a question potentially for DataLoch, for Dr. Anand, but certainly there's two different ways of looking at that. Through the university community, as an academic interest, there's certainly ways of looking at questions with different predictors and different outcomes, but also to service innovation level using DataLoch, using anonymized data and feeding things back to clinicians. So the short answer is yes, and it depends on your question, and we're happy to point you to the right place depending on what the question is.
Okay, cool. And then Katie McWilliam says she's wondering where the connections are being made with ScotGov, GUF, Gerfec, get it right for every person, for everyone approach. It used to be Gerfec.
Yeah, yes, well, it came from the getting right for every child, and I was getting right for everyone, because, you know, we've got to get it right for everyone. Hi, Katie, nice to see you. Yes, absolutely. We are making connections with Scottish Government on that, both through Usher Innovation and also through Advanced Care Research Centre. So shortly, yes, there are connections, and very happy to talk to you further about that. And
can the data be used to support different programmes across government, looking, say, at inequalities, deprivation, ethnic diversity?
It's a key thing about data. You know, data is power, and I think that it's important to have expose the data so we can understand things better. But I think it goes also back to one of the previous comments we had. It only is about as good as the data themselves are, and are they really reflecting what we think they are? And so a lot of the information is about making that as clear as possible and making sure we get the right answers to the questions we're asking.
And skills development, etc. We're going to move into those wider questions, I think, now when we call together our panel. We're going to have a panel discussion involving Dr. Marcus Harrison, Dr. Grace Vickers, Dr. Atul Anand, Garrett Sprague, and Susan Shenkin. And we'll be playing in any questions that you, as an audience to this discussion, might want to ask. So please put those in the Q&A box thing on your screen, and I'll do my very best to pick that up. So I think we might have our panel convened. I'm trying to move windows around on my screen to see if we can see everyone in Viz. I was going to go first to a question that I think picks up on what Susan Shenkin raised there at the end, which is, this comes from Simon Bradstreet, and I'm going to put it to you first, Susan, and then anybody else that wants to pick it up. Simon Bradstreet says, in our work with DDI and HSCPs, that's health and social care partnerships in the region, we found no lack of desire for the better use of data, but a lack of analytic capacity. How can we prioritize and increase these skills in the system in the context of cuts? The first time we've heard the cuts word. Susan Shenkin.
It's a really important question, and I think there is something about where that expertise needs to sit. So should health and social care partnerships have data analysis capability, or should that sit in academic institutions and be fostered by collaborations like this one? And I don't have an answer to that question. I guess it depends on where the finances sit and where the expertise is, but certainly our work with the Midlothian partnership that I was part of gives an exemplar of how working together across those sectors can add value in both sectors. So I would suggest that that's a good way to start. And we also need to build the capacity, which is clearly a priority in many of the things that are going on in the university and developing these talent for data-driven innovation.
Grace Vickers, I wonder if I could ask you to come in there. Midlothian's name checked just before. But yeah, this skills development, how big an issue is that?
Yeah, I think it's a massive issue, Penny. And I think if we're realistic, I don't think every health and social care partnership would be able to have analysts in that way. So we need to work collaboratively. For us, I mentioned the Centres of Excellence model before, so skilling up our children and young people so that they can access that employment. But I do think pay structures do come into it, because if you're thinking about private industry can actually pay more for that. So I think we need to be realistic in the public sector. If we're really going to do this and do this well, we need to work collaboratively. But most importantly, I think develop our children, young people, to take advantage of those very important future skills that they're going to require coming through. And I don't think you can underestimate what our children, young people can do. For example, in one of our primaries, Roslin Primary, they're currently working with a volcanologist and using the Internet of Things to actually understand the atmosphere. So I don't think that these just have to be jobs for people with degrees that are certainly our children, young people that can really help us in this collaborative effort as well.
Yeah, thank you so much. And Atul Anand, you know, you're talking about bringing together data sets here from very broad sectors: primary care, secondary care, social care. Those skills issues, have they, you know, come to the forefront of your thinking?
Yeah, definitely. I think this is part of the wider DDI program, which has a real strong focus on talent and building up talent within the region. I think the analyst question is a very, very valid one, and the DataLoch teams are very lucky through the funding of the city region deal to be able to expand our analyst pool over the last few months. But even then, there's so much more we could do, but it is difficult. A lot of I think the real benefit of the approach that we're taking is around trying to automate what previously would have been done repetitively again and again, for example, to prepare data sets. So that can really help with that idea of curating research-ready, innovation-ready data sets, so that actually the burden on analysts for individual projects is reduced, because a lot of that work is being done more systematically up front. So I think there are opportunities to make analyst time go further, but it is a challenge.
Yeah, thank you. And Garrett Sprague, it sounds to me from your presentation that that data skills issue isn't such a huge one for the project you described, but access to people, to individuals, is your issue, yeah?
Absolutely. I mean, we've had to kind of go from the ground up to work with partners to build our data set. And that's really, I mean, I can't tell you the number of individual presentations to everything from kind of scheme managers at a housing association to senior level leadership at, a care home kind of conglomerate. We've gone all the way kind of boots on the ground to kind of build this data set, and it's been a difficult process. And so I think the extent to which this collaboration could kind of create a pool of individuals who are interested in piloting technologies or kind of working on innovative research like this, it would really expedite the process and kind of build a lot more confidence for us to bring more funding into this type of activity from funders out there. So
yeah, thank you. And then Marcus Harrison, there's a question again posed by Simon Bradstreet, but I wonder whether you could perhaps respond to this one. It's will learning be shared with similar data-driven health innovation programs in Scotland? So I think we've heard about safe havens. For example, in Murray, DHI are leading a similar but different model of innovation support, and there will be valuable learning across such programs. So that intersectional analysis is going on, is it?
I think we're at the sort of start of the journey with this DDI program. We've sort of been building and developing the capabilities and infrastructure. I think we're now at that point where we are, as part of today actually, is actually opening it out and starting to sort of collaborate with people more widely. We feel as though we have a solid service here and a good platform to sort of build on. So yes, we very much sort of want to welcome these collaborations.
So what do you want to hear, Marcus Harrison, from the people that are joining this webinar? Is it about, areas that they would like to explore for common good, or specific projects coming your way, or offers of help? How will people interface?
No, it's an interesting question. There's in a wrap up at the end here, there are a number of the examples here of the types of projects that we have already worked on over the last couple of years, and the sort of the direction of travel of where we want to be working on. And I think one of the reasons today to sort of set for today, and also setting up the LinkedIn page, is to encourage people to come to it, to sign up, get in contact,
and so therefore shape this collaboration as it goes ahead. We'll come back to some of that. But I wondered if I could pick up a question posed by an anonymous attendee, and let me put it to Susan Shenkin first. How are you going to navigate the issues of informed consent, especially for frail people, for example, with dementia? And how would you pull data from the DataLoch and the models developed by third parties if individuals removed their consent and asked their data to be removed? Let's not get into the detail of that question, but this issue about consent and informed consent, how do you address that?
Yeah, it's a really important issue, and I think that's something that we're considering really carefully, because there's two sides to informed consent for people who lack capacity. People who lack capacity have the right to also take part in research if they want to do so, or would have wanted to do so before they lost their capacity. So how do we have meaningful conversations about what people would want to do, even if they're no longer able to make those consents for themselves? And looking at routine data gives them an opportunity to take part in research when they can no longer actively do so. So that's an opportunity, but it's also something we have to be cautious around and make sure we have appropriate ethics and governance around that. So there are complex issues here, and I think we are very mindful of those as practicing geriatricians as well as academics.
Are there extra issues when it comes to data and management of data than from normal clinical practice? Because you're going to encounter that on all sorts of fronts, aren't you, with informed consent? Are there specific issues here to consider?
Well, I think it also depends on how much of the data we're going to use is identifiable and how much of it is used in a non-identifiable way as well. And the infrastructures for that are quite different. And Atul can probably speak also from the DataLoch perspective about the ethics and governance around using this cohorted data that's anonymized and then can be presented more broadly to be used in that way.
Yeah, thank you. And Atul Anand, then to pick up from what Susan Shenkin, the point you made.
Yeah, so exactly. So I think I completely agree with Susie's point. So there is an opportunity through de-identified data to allow people who don't have informed consent with dementia to be included in research. I saw in the chat there were some questions about dementia work as well. It's really important that we allow the inclusion of these people in that kind of work. I think it's very different when we think about an innovation challenge where we might be talking about technology in people's homes, where there's clearly a different threshold. And that's a sort of thinking that we are currently working through in the design stage. But yes, it's important that I think we don't forget about the key point that Susie made there about trying to include people as much as possible where they would have wanted to be included. And we know that sadly a lot of traditional research has systematically excluded older and frailer people. And that we all suffer because of that, I think.
Yeah, thank you so much. And I mean, I think Grace Vickers, that's really the point about place, isn't it? Go to where people are, because it's really important that we don't just stay within the traditional parameters around this. Yeah. Do you find that people are willing to take part? I mean, I'm talking service users here.
So far, we've had a really positive experience, Pennie, and I think a big part of that was because it was something identified by our GPs. So they saw it as a real issue. And I noticed that I think it was Roger in the chat had asked, what is the role of GPs? And I think that's really important when it's identified at that level. They have excellent relationships, with their patients. And I think people need that trusted individual first in order to connect in and understand what are going to be the benefits for them.
And what proportion, for instance, of general practice do you find is willing to sort of go with you on this journey to where it needs to take them?
So we've had really positive engagement, but we only have our 12 GP practices, which in essence is one cluster. So I can't really talk for other clusters of GP practices across the country. But I think when they're working towards something where it's a common goal. So as I said in my introduction, our GPs were thinking that's their climate emergency. They're seeing this coming down the track with a really fast growing elderly population that unless we really tackle it now, our system in Midlothian would fall over. So I think it was that shared endeavour to do something about it before it was too late.
Yeah, thank you so much. And if I could go to Atul Anand with a question that's come from Keith Allen here. Keith's saying there's a role for public health here. They have consultants trained in research methods and epidemiology. Has there been any communication between directors of public health, for instance, and DataLoch? Are they included in this loop, Atul Anand? Well,
so this is definitely part of the community we're trying to build. There's a lot of methodological expertise within the Usher as well. So there's lots of these, brilliant opportunities to create connections, and we would really love to have more clinical academics who bring both of those elements of the clinical understanding plus the research methodology, because I think that is important. So definitely please do get in touch, or we can reach out.
Thank you so much. Now, just to move on through any other questions that have come in. Yeah, who's the propriety owner of the data? I've put in the word owner there. I'm an anonymous attendee has asked. I mean, Atul Anand, I wonder if I can ask you that one just now.
Yeah, so I mean, the data it doesn't, I suppose, belong is a quite a pejorative term, I think, but the data controllers remain the NHS or the health and social care partnerships. What we do in DataLoch is to bring that data together on behalf of those organisations, and they very much still in charge. I think there was another question about GPs agreeing for the use of data from Roger Halliday, and so yes, we have active GP involvement in that. So the 100 GP practices in Lothian that individually signed up to DataLoch. That doesn't include every GP practice in Lothian. There are a small number that haven't, but it's around 85% of practices that have agreed to be involved, and so that's a really good start. But we want to understand where there are challenges and where GPs are not wanting to be part of DataLoch. That's absolutely fine, but it'd be good to try and work through those and understand some of their concerns that they may have. But yeah, generally it's all based upon active involvement.
Sounds like a research project in its own right, because it doesn't take a lot to imagine that once this is a critical mass, it's going to be hard to stay outside, surely, for the benefit of patients.
Yeah, and we absolutely want to deliver value back. So some of the reports I showed around multimorbidity and frailty, that's very much about trying to give back value to GPs within that DataLoch environment.
Yeah, Marcus Harrison, I think I'm hearing very strongly that there's such a lot of learning taking place right now in terms of individual projects, in terms of, how do you get participants on board, be they GPs or service providers or service recipients. How can the collaboration encourage this kind of learning that means that you don't have to reinvent the wheel every time you go out on a project like this?
In terms of the projects around sort of DataLoch in general?
Yeah, whatever connections are made through the collaboration, how can individuals learn from the experience of others who are building these projects and making these discoveries and developing these data sets?
I think one of the first things we need to do is to really carry on building on the long-standing partnerships with people to make sure, we talked about here about bringing more data into it, expanding it across the southeast Scotland region in its totality, and connecting with other areas of Scotland. But then in terms of the collaborations on the projects themselves, I think it's very, very important to communicate the data sets will be formed, as Atul said, and connected. So as we build those, there will be a strong foundation of which it'll be easier to go in and explore the data. And then on the collaborations themselves around specific areas, what we do need to do is find the common purpose and actually communicate what the outcomes and the benefits to society have come from. And I think by doing all of those together, I think it will gain momentum. I think we are still at relatively early stage, but momentum is really building here.
Well, we'll get the chance to talk about what happens next in one moment, but Ryan Cooper has a question for Grace. Does the data you talked about demonstrate the amount of hospital visits from the mid-high frailty index for diagnostic tests, for instance? Near patient testing closer to the patient's home could reduce hospital visits and increase diagnostic result weights, increasing frailty management closer to their home. So I think if I were to summarize that, say, are there unintended consequences, says Ryan Cooper.
Yeah, and I think, so I showed the slide, and so we understand between, mild, moderate and severe frailty, the percentage chance of increased hospital visits. So we were looking at that, particularly in the severe frailty, 70% more chance of hospital visits. But there is also linked in with that, Pennie, the issue around delayed discharge. So really knowing that you have a care plan for somebody, and if they are in hospital, what additional things are we putting into that to ensure that we don't have repeated hospital visits? That's actually the key. We're not there yet on that, but I think we need to do that as a whole system. Otherwise, we will never manage to, I suppose, answer this question about delayed discharge. So we can't just focus on that being the issue alone. We need to work out what what are the other factors within that that allows people to live longer in their own homes, particularly after their first hospital visit. So we can do a lot about the prevention, but actually there's a lot that we can do at somebody's first hospital visit to prevent those repeat visits.
Thank you very much. And then from Emily Lekas here, and I'm going to put this first to Atul Anand, if I may. How do you envisage the best approach to adoption of innovation by the NHS and social care services in Scotland? Actually, now I'm going to ask everybody to respond to that, I think. So we're going to have all this research, all this data gathering, you know, how would you then roll that out to make improvements on the ground? Atul Anand.
Yeah, so I think that is the fundamental question, isn't it? Because a lot of stuff is done and published and looks brilliant, but it doesn't ever seem to make it into practice. And so I think part of the approach that we're trying to take is to involve those potential future service users right from the outset, whether that's a health and social care partnership or the NHS directly, so they're involved in the design, for example, of the frailty challenge that Susie mentioned. And it's being delivered within an NHS framework so that should it be successful, there's a natural progression into adoption. Where I think previously these things have been seen as two separate stages, and you get through the first stage and then you think about the second. I think we're trying to get that kind of continuous flow if we can.
Yeah, so Susan Shenkin, again, name check there, you know, how do you see, you know, the learning and the rollout as a result of the work that you're doing on data gathering?
Yeah, I think we all agree geriatricians are by nature collaborative creatures, and I think this exemplifies this collaborative focus, and the Usher Institute also exemplifies that. Actually, we're not working in silos, but working across disciplines and speaking together from early on to start to make those pathways clear, rather than inventing the widget and finding the market for it. And Garrett exemplifies that as well, talking to the individuals to start with and see where that's actually going to go. I think, you know, we need to have everybody in the conversation. No one of us is going to be able to solve that on our own.
Yeah, thank you. And Garrett Sprague, you know, how unusual is it to be taking part in this sort of conversation where you're talking, you know, academics, industry, etc.?
I don't know if it's unusual. I mean, I think it's a conversation that needs to be happening, right? I mean, we're talking about unprecedented scale challenges, and if we're not going to find ways to collaborate across with, you know, public and private sector and across, build conversations between people who might not have had conversations in the past, right? And I think that's what Usher is probably set up to do in their convening role here, is bring people together to drive things further faster.
Thank you. And Grace Vickers, you know, you're Chief Executive of Midlothian Council. One of your big challenges is reducing inequalities. I can't be the only person that looks at the way the world is going right now and thinks, gosh, we thought we had it bad before. This is really something else. How can data help us to close that gap in your experience, or even in your dreams?
I agree with you. It's becoming an increasing challenge, isn't it, Penny? And we know that health inequalities are greater for those living in poverty. So for us, data is absolutely key. We need to target that. So in Midlothian, we have 3 targeted identified communities, just to give you one example. And we work together with all our partners, including our Director of Public Health. And that's absolutely critical for us to understand our communities and put that targeted intervention in place. And I was quite disappointed because a recent figure shows that 24% of the children in Midlothian are living in poverty now. And that's huge for a relatively small local authority. And that in itself tells you about what the life chances of those young people's journey is going to be. So I can't underestimate the importance of data. And I'm just reflecting, Penny, on Dave Griffin's comment. He says, how young should you target participation? I'd be really keen. I'm a real fan of that lifelong journey of people and planning the services that you're going to need, 10, 20, 30 years down the line. And I'd love to use data to get better at doing that. I think we'd all be in a better place because we can change some of those behaviours. And I just think the scale of the challenge is so great that we need to do that collectively together.
Thank you. We're getting some fantastic comments and contributions from the people that are taking part in this discussion. So thank you so much for that. I mean, we've got a question about risk management that I just don't think we've got time to go into here, but I suspect this collaboration is the place to bottom that one out, Martin, Sherry. So we'll see about that. And then an anonymous attendee, I don't know if it's the same anonymous attendee or a different one, but I'm going to put this to Garrett Sprague. How can projects like this be used to demonstrate the value of information management as a professional discipline, do you think, in the world that you operate in, Garrett?
Wow. I feel like I'm getting the really technical questions here.
Oh,
yeah. No, gosh, I don't know. I think from our perspective right now, what we're focused on, the algorithms that we develop will track towards becoming medical device certified. So the level of the sort of regulatory environment that we're operating in, even at an early stage as a startup, the emphasis on trust and data security, to Martin's point earlier. I mean, we're far down the way from a quality assurance perspective of actually getting ISO certification, right? And then these are standards that are set up that a lot of early stage companies have difficulty sort of tracking towards, but they set expectations and they're beyond just minimum operating procedures to give confidence to the market, to the community, that the solution that you're bringing or trying to accelerate to bring to market is up to a standard with kind of what expectations are. So yeah, it's not an easy thing from an early stage startup perspective.
No, it's really interesting. Thank you so much for that. And Marcus Harrison, I know that we're moving on to a discussion with you about what happens next, but I wondered whether Audit Scotland recently published a piece that called for radical action being needed on data. To sum it up, how important to Scotland do you think is the kind of innovation that your organisation represents?
I think as we look for new products and new services, we need more data. We need more data. We need the tools that sit on top of it to understand it and come to conclusions. So I think the more connected data that we can get, I think the better we can actually bring that benefit from the work we're talking about today, but I think more widely and society in general.
And collectively, well, Audit Scotland said that we need to build a wider, a bigger, a stronger data culture. Collectively, can this collaboration help to shift that? Can we move? It's that culture word, isn't it? Can we kickstart something here?
That's the intention. Yes. We've made quite some good ground, and yes, that's the direction of travel, we hope.
And then finally, to pick up on a question from Martin Williamson before we move on, innovation versus cuts, writes Martin. Governance-wise, how will Usher DataLoch ensure that ideas and activity definitely align strategically with HSCP priorities, targeting must-haves rather than just nice-to-haves? That's making the assumption that HSCP priorities are the right ones, isn't it? The data may say otherwise. What would happen if that was the case? Maybe I should leave that at a ... and we'll pick that up later and perhaps explore that through the community. Right, okay, now we're going to move on to the section of the programme that is about how people can get involved. The breadth of experience that's demonstrated in the chat and the Q&A function here would indicate that it's got quite a broad reach. But Marcus Harrison, you're going to tell us how people can join in.
Thank you, Penny. So we've just got a couple of slides to sort of finish up on. Okay, next slide, please. So we've heard quite a bit today of the key areas where we can have a contribution by using the data-driven innovation. And Atul's given a really great example on the service management side. There's some great research around cardiology algorithms. There was a separate webinar the other day on this. And how we can sort of connect us also with industry, because industry do have a significant part to play in this, as we found from Garrett and there's other small companies that are around in the region, and also the impact on policy. So I think there's a huge amount we can do here across a broad range. And I think this is really what we've done so far is just the tip of the iceberg. Next slide, please. We've had about 72 data releases of projects to date. Again, really, I won't go through the details, you can read some of them here, really broad areas, and some of it was related to COVID too. And, you know, we just want to sort of keep growing that and sort of really utilizing the use of this data and the connectivity that is happening. Next slide, please. So how can you get involved here? Is, you know, to help develop data-driven solutions to the challenges we've been talking about. Please get in touch. There's ways of doing this through the Usher Innovation Community, which has just been launched today and has gone online. Just through the website at University of Edinburgh, and also email us directly. And I think mentioned earlier, we're going to do these in challenges. We've talked a lot about frailty today, but there'll be others, including sort of oncology and respiratory and mental health sort of coming down the line over the next few years. And, you know, whether you're an academic clinician, you're working in social care or industry, we really want to hear from you so that we can all work together and solve these difficult problems in a collaborative manner.
Thank you.
Thank you very much.
Thank you so much. If there are people here that can answer that question, how do we connect with industry? Please put your thoughts, your comments, your questions in our feed, and they will get picked up. There was a question here, I don't know if it was directed towards this particular issue, Marcus Harrison, but, you know, are you going to actually, anonymous attendee, God bless you, anonymous attendee, you've kept the questions going. The question is, will you facilitate connections in the community or rely on setting up connections for others to find each other? I wondered from your perspective, Marcus Harrison, whether you could answer that one.
I think we need to do both. We already have people sort of contacting us, and we may or may not be involved. Not all projects are going to involve DataLoch, for example, and we will just sort of we will try and set up a way of facilitating that as easy as possible. For now, we're looking to sign, you know, as a starting point, looking to find people who have an interest.
Yeah, thank you. And Marcus Harrison, you were involved very closely in the COVID-19 response, yeah? Can we keep that sense of urgency that shifted so much and achieved so much? Can we keep it in terms of our focus on data and even accelerate it, do you think?
I think with the changes that happened during the course of the last 3 years, this whole digitization has been incredibly fast. It's probably happened years faster than people envisaged. So I think now we have that information and we have those processes and tools in place. I do think there's a way we can sort of accelerate this further.
Yeah, thank you. And Sven Bolu, forgive me if I've mispronounced your name, but has a question that's a great one to give you about a minute and a half to answer. But what are your very concrete expectations towards industry is the question. You know, what do you want industry to contribute and what can you give industry to participate in this community?
I think as we've seen, you know, today, Garrett's a great example here of some of the real innovation that's going on within industry, particularly sort of small, medium-sized enterprises. I think, you know, what we want to do is to get them to come forward, talk to us early on, so we can actually allow that new technology to be adopted as rapidly as possible and quickly into the NHS and social care.
And then just to point out to everybody that in the chat function on your screen, there are links to joining this community on LinkedIn, and you can find out more information on the website. So just to wrap this webinar up, I wonder if I could ask Marcus Harrison, you know, what is your vision for this community? What would you like to see it achieve? What will be your measures of success?
I think from the community, we want to get collaborations of the right groups of people with a shared vision to solving the problems. That will be the first part, and then rolling them out into society is the next step.
Yeah, thank you so much. Well, that really brings us to the end of what has been a fantastic and fascinating for me webinar. Thank you so much for wonderful presentations, but also really thank you so much to everyone who has engaged with this online. And I just wish you all the very best of luck with it and more power to your elbow. Thank you so much and goodbye.